So sorry for that. So joining with us today to walk us through the session of wound management is Sister Sheeba RS, who is currently heading the on-site training department of TIPS, Trivandrum Institute of Palliative Sciences, the training wing of Pallium India. She has completed her palliative care foundation course at Amrita Institute of Medical Sciences, Cochin, Kerala, and she had worked in the Department of Palliative Care at RCC, the Regional Cancer Center at Thiruvananthapuram, before joining us. She strives to emphasize the need of palliative care training in budding nurses and doctors of India. With an extensive 18 plus years of experience into nursing, she is also a certified trainer at the National Health System Resource Center NHSRC, and she is recognized as the pioneer nurse by St. Christopher Hospice UK, the world's first hospice in the year 2020. So, believing that this session will be an enlightenment for you from the nursing point of view for the wound management, and for many more practical knowledge will be gained from this session. Sheeba ma'am, it is over to you.
Thank you, ma'am, for the nice introduction. Good afternoon to all. Happy to see you all. As ma'am said, today we are going to learn about wound management. So you might have seen different types of wounds in your settings, but in palliative care, mainly we have seen two different types of wounds. One is pressure ulcer, and the another one is fungating wound, cancer wound. So let's see the pressure wound first, and then you can move on to the next part. So I hope the screen is visible to everyone. Okay, next slide.
Yes.
Okay. Yes. So we all know that what is wound. Wound is a break, any break into the continuity of the tissues called wound. So what is pressure ulcer? Anyone, can you please unmute yourself and talk? What is pressure ulcer?
This is a kind of ulcer which is there because of the long pressure over the skin for long hours, for long days.
Okay.
Just because of the pressure, pressure because of large tumor or large mass or anything else.
It's over any bony area, no, over the skin actually. So that bony pressure area. So,
okay. Any other answers? Okay. Okay. So pressure ulcer is a localized injury to the skin and other underlying tissue. Okay. So as you said earlier, it is a localized injury to the other underlying tissues, especially over the bony prominence as a result of prolonged unrelieved pressure. So if there is a unrelieved pressure there, so there is a chance of damage of underlying tissues, especially on the over the bony prominence. This is pressure ulcer. So these are there are three main causes, major causes of pressure ulcer. So one is unrelieved pressure. The second one is friction. The third one is moisture. These are the three major causes of pressure ulcer. So another pressure, there are different names also. Pressure ulcer, bed sore, and the another one is PSM wound. PSM wound is pressure, shear, and micro environment wound. That is PSM wound. And the one more name is HAPU, HAPU, hospital acquired pressure ulcer. So when the patient come to the hospital, there is no pressure ulcer. But after that, the patient has developed pressure sore within the hospital. Then we call this HAPU, hospital acquired pressure ulcer. So these are some images. So it can occur anywhere. So next we can see the pathophysiology of pressure ulcer. This is the pathophysiology of pressure ulcer. So why I am telling this pathophysiology with you is, so whenever you have seen a bed-bound patients, you have to teach the caregivers about preventing pressure ulcer, how to prevent pressure ulcers. You have to keep it in mind and tell them that, so this is how the pressure sore can occur. So this is very, very important. So you can imagine a patient is lying on a bed. So there is a pressure. So because of the body weight, the bone will be compressing the underlying tissues. No. So that time, so the tissues, may not get adequate nutrition from the blood vessels. So if there is a prolonged unrelieved pressure there, that leads to collapse of blood vessels. If the blood vessels will collapse, the tissues may not get adequate nutrition, then gradually tissue ischemia, and then finally stress and breakdown. This is the pathophysiology of pressure ulcer. So we need to change the position every 2 to 3 hours. So this is the important message you have to tell the caregivers about for preventing pressure ulcers. Next. So next, we move on to the risk factors. So can you tell me the few risk factors of pressure ulcers? Either you can unmute yourself and talk, or you can put the answers in the chat box. So what are the risk factors of pressure ulcers? Immobility, okay, fine. Malnutrition, very good. Okay, age. Some disease conditions, okay. Paraplegia, so if the patient is become paraplegic, they may not be able to move along. So the patients can get pressure ulcer. Paralysis, okay. Soiling, okay. Any other answers? Okay, so thank you for your contributions. Let's see one by one. The first one is friction. So, so friction is the major risk factor, because for a bed-bound patients within the hospital, we have nurses. We are there to take care of the patient, bed-bound patients. Our nurses know how to change a bed sheet from a bed-bound patients, but the caregivers doesn't know. So when they go back, what happened? They pull the sheets under the patients. So when they pull, so there is a chance of friction between the skin and the linen, the cloth. So that that time, if there is a small the peeling of skin there, so that in bed again, if you give further pressure on that area, definitely the skin will break down. So this is the first risk factor. Next is shear. So this, just imagine a obese patients. So usually they're slipping downwards to the bed. So when we reback to their normal position, what happened? So we call maybe more than one person, maybe two more persons, and we we try to pull the patients up. Okay, so there is a chance of tissue damage. So we don't know if there is any tissue damage is happening or not. So if we apply again pressure on that area, so there is a chance of bed sore development from that area. So that is, maybe it will be affecting the subcutaneous tissues also. Okay. So deep injury. And the third one is impaired sensory perception and impaired physical mobility. So as one of you mentioned about the paralysis patients, the paralysis patient. The paraplegic patients, they may not get lower the lower part of the body. Okay, so if they want to move, turn from supine position to that side lying position, but then they may not be able to turn independently. So they need support, they need help. So that kind of patients can also develop pressure ulcer. And also if there is a spinal cord injury developed, there is a chance of fecal and urinary incontinence also there. So if there is a fecal and urinary incontinence there, again moisture. So moisture is also a contributing factor. Altered level of consciousness, either semi-conscious patients or an unconscious patient, then may not be able to turn independently. So that patients can also affect pressure ulcer. Then fecal and urinary incontinence, I already said that there is a chance of moisture all the time. So moisture is another cause of pressure ulcer. This is also one of the risk factors. Malnutrition and dehydration. This is very, very important. One of you are mentioned about the malnutrition. So nutrition is also very, very important. Even if you turn the patients every 2 to 4 hours early, you put the patient on air mattress, even then the patients can develop pressure ulcer, maybe because of poor nutrition. So lack of protein intake in their diet can cause pressure ulcer. Dehydration. So you have to if there is a dehydration there, the blood volume will reduce and the tissues may not get adequate blood. So that dehydration is also one of the contributing factor. And excessive body heat and advanced stage. So these are the common risk factors of pressure ulcers. Next, move on to the common sites of pressure ulcer. So it can occur anywhere. So you can see that, imagine even if the patient is on wheelchair also, the patients can get pressure ulcer. So it can occur, usually it can occur on the bony prominence, but depends upon the patient position, it can occur. So we can see one by one. So you can see the images: heel, occiput, scapula, sacrum, toes. Even so, toes also affected with bed sore. So these from these images we understand that it can occur anywhere. So coming to the supine position, so here these are the common the bony prominence that the pressure sore can occur easily. So these are the points. Why I am telling the points is, so whenever we turn the patient from supine position to side lying position, we need to give a special attention for those areas. So this is very, very, if there is any color change there, you have to give a special attention on that area. So white toes is sometimes it will, one chat question is, why the toes is affected with bed sore. So the answer is, sometimes the toes will touch the side rails. Sometimes the toes will touch the wall. Sometimes the toes will be covered with the heavy blankets and sheets. So that if there is a continuous pressure on that the same area, there is a chance of pressure ulcer formation. And next is side lying position. So when after supine, maybe after 2 to 2 hours, you have to turn the patient from supine position to side lying position. Even if the patient is in side lying position, also you can see ear, shoulder, elbow, hip, knee, heel. These are the common major pressure points. So when the patient is in side lying position, so one important thing you have to keep it in mind, in between the knees, there is a chance of rubbing together. Okay, so there is a chance of friction happening in between the knees. So always you have to keep a small pillow or a folded sheets in between the knees when the patient is in side lying position. Okay. So coming to the Fowler's position, we all know that this is the good position for a dyspneic patients. Breathing difficulty patients, we usually put this position. Even if the patient is on Fowler's position also, that patients can get pressure ulcer. So these are the common points. What you can do is at least a 10-degree turn is mandatory. So no need to put the patient is in the side lying position or supine position. You can keep this position continuously, but you have at least a 10-degree. The turn is mandatory. Okay. Coming to the prone position, here these are the major pressure points: head, elbow, chest, reproductive organs, knees, and toes. These are the common points. If the patient is having that large bed sore on the sacral area, we keep the patients like this. And also if there is okay, we can. Okay. So if there is a fourth stage pressure ulcer there sometimes we used to give skin grafting procedure. So after that, the patient is keep at least 3 weeks the same prone position. So before that also we try to keep we will train the patient for a prone position. So at least we check whether the patient is tolerating on the prone position also. So prone, even if the prone position also, the patients can get pressure ulcers. Coming to the stages of wound, so how many stages are there? Can anyone say how many stages are there?
4.
4 stages. Any other answers? Four. Any other answers? 4. I am waiting here for your answers.
Actually, it's another variant of stage 4 is there, I think. That will come to stage that actually we can say stage 5.
Okay, thank you. Thank you, ma'am. So thank you for your answers. There are 5 stages. The first stage is non-blanchable erythema. So it looked like this. One more. So it looked like this. Okay. So if there is if you have seen these kind of changes in the skin, so if you apply your finger pressure on that area, that redness is there, will be there. So that is called non-blanchable erythema. Next. Okay. So this is the stage 1. So non-blanchable erythema. So the stage 1 management is, so you have to prevent further pressure on that area. If you have seen the notice or first stage the pressure sore, you can prevent further pressure on that area. That is the management of stage 1. Okay. So if you are not treated, in the first stage, so definitely the skin will break down or blister formation will be there. Okay, one more. So the blister formation will be there. So if there is a blister formation there, definitely the skin will break down. So this is the stage 2 pressure ulcer. So there is no slough, no pus formation, only clean wound. So you can clean with normal saline. Okay, normal saline cleaning is enough for this kind of wounds. So next is third stage. That is all full thickness ulcer, all tissues will be affecting. Okay, all subcutaneous layers will be affecting. Sometimes tunneling will be there. So what is tunneling? So tunneling is a narrow opening or a passageway that can extend in any direction through a soft. You can imagine, you can see that images. So you, if there is a tunneling present in the wound, you have to do the proper assessment and check for tunneling also. If there is a tunneling there, you have to give a special attention on that area. So otherwise, that wound won't be healed properly. So that is very, very important. When you're doing, when you assess the wound, you have to check whether the wound is having any tunneling or not. So I'll come to the management later. So this is the third stage. Sometimes the slough will be there, black necrotic tissues will be there. So we need to remove it. So I'll come to the management later. So the next one is the fourth stage. This will be exposed muscle, bone and tendon. Okay, so fully exposed muscle, bone and tendon will be there. So you can see that images. So we can see the bones and muscles in this wound. Next. So the fifth one is unstageable. So if there is a unstageable, if there is a black necrotic tissue on the top of the wound, we can assess the stages of wound. Okay, so that is unstageable wound. If there is a black necrotic tissue on the top of the wound, we can assess the stages of wound. That is why we call it as unstageable wound. When you document it, you have to document it is an unstageable wound. So if once you remove the top of the skin, maybe that that unhealthy tissues from the wound, then only we can able to find out whether the injury, whether the pressure ulcer is affected into the deep the subcutaneous tissues or muscular muscles or tendon. That time you have to document it is an unstageable wound. So we have learned 5 stages of wound. The first one is non-blanchable erythema. The second stage is the dermis layer will be breakdown. And the third one is full thickness ulcer, that is all subcutaneous layers will be affecting. The fourth one is bone, muscle and tendon will be affecting. The fifth one is unstageable. If there is a black necrotic tissue on the top of the skin, we can't assess the stages of wound. That is called unstageable wound. So coming to the assessment part, doctors and nurses. So anyone will see a bedbound patients, you have to see even a bedbound patient and a wheelchair patients, you have to assess the patient properly. So if you do the proper assessment, definitely we can able to find if there is any color change there, you have to find out easily, and we can able to prevent further damage also. And what are the things you have to assess? You have to assess the pressure points. The first one is you can check the pressure points. Is there any color change or any damage, any peeling of skin? All those things you can assess. And assess for pain associated with. If they have a wound already, you can just ask them whether they have pain. So if they have pain, you have to give some analgesics before that, and then you can do the dressings. You can wait for at least 45 minutes, and then you can do the dressings. So that is one important thing. So the pain assessment is mandatory, and assess location. So or the location also site, and measure width, length, approximate measure the length and depth you can assess. And stages of wound, we know what are the stages. You can assess the stage and presence of exudate. Exudate means that oozing out of fluid or purulent discharge from the wound, that is exudate. You can check for that, assess for tunneling, and all those things you have to document it properly, because so the next time when we do the follow-up, you have to just cross-check whether your treatment is effective to that patient, and also your that friends or colleagues will help, maybe get the details from the patients. Without, if you are not available, if you document it is very well documented properly, they can take the file and go through the file, and they will know all the details of the wound. So this is very important. And management part. So we now we understand that what is pressure ulcer, what are the risk factors of pressure ulcer. So what are the sites of pressure ulcer and stages of pressure ulcer. These all things, how to assess pressure ulcer. Then now we are moving to the management part. So as I mentioned earlier, always medicate the patient's pain before wound management. So this is very important. You already know what is pain. So pain is what the patient says first. So this is a subjective experience. So you have to ask the patients. We can't say you don't assume. So this is don't assume. We need to believe the patient words. So you have to assess the patient's pain before wound care. So coming to the stage 1 and 2, as I mentioned earlier, so you have to, if there is a non-blanchable erythema there, if there is a color change there, you have to teach the caregivers about the turning techniques. So you have to prevent further pressure on that area, particular area. So you have to teach the patient about the turning techniques and excellent incontinence control also. If there is an incontinence there, definitely the skin will break down. There is a chance of breakdown. So you have to train the caregivers about that. And coming to the second stage, so only clean wound, no slough, no necrotic tissues. Here you can clean with normal saline. That is enough for second stage of wound. Coming to the third stage, third for an unstageable wound, if there is a slough, black necrotic tissues there, you can do the surgical debridement. Okay, you can remove the slough as much as you can. And also you can clean, always use normal saline for cleaning. You see, you can teach the caregivers about homemade saline, how to prepare homemade saline. Also, I'll come to later how to prepare a homemade saline. So if there is an odor or infection there, you can apply metronidazole powder. So here what we do is take metronidazole and crush it, make it a powdered form, and mix with a white petroleum jelly and apply on the wound. So that time the metronidazole will reduce the infection and white petroleum jelly will give a moisturizing effect to the wound. Okay, so this is how we manage here. And also you can use debridase ointment. So that is quite expensive, but if they are affordable, you can that give these medications. If there is a slough there, so this debridase ointment will help to remove the slough. And once the slough is removed, you can apply mega heal ointment. That is also quite expensive. If they are affordable, you can give these medications. Even if they are not affordable, if you can give this medication, that would be better. So here we usually apply metronidazole powder, but if surgeons suggest these kind of things, we usually apply on the wound. And if there is a malodor, so malodor there, you can give charcoal dressings. So and now the charcoal dressings is also available, but the thing is expensive. So if they are not affordable, you can give charcoal pieces. So that is very cheap. You can make it in your home also. So they can also make it in their own home. So this charcoal will help to reduce the bad smell. So this you can suggest, and you can try to avoid use of hypochlorite solution like povidone iodine and hydrogen peroxide for cleaning the wound. Okay, so it will destroy the granulation tissues. And the next the management is surgery consultation. As I mentioned earlier, if there is a stage 3 pressure, 3 or 4 pressure, especially 4 pressure ulcer. So if the patient's health status is okay, we used to call the surgeon's opinions, take a surgeon's opinions. And if the surgeons suggest, okay, wound the skin graft procedure is possible, then we can do that. So always you can do the surgery consultation. If the patient's health status is okay, then you can do that also. And the next one is negative pressure wound therapy. One more. So this will help to remove all exudate from the wound, and also continuous continuous pressure. Because of that continuous pressure, that will stimulate the blood vessels, and that wound will get more blood circulations, and gradually the wound will heal properly. So the main aim is to give negative wound pressure therapy is with the help of suction apparatus. Also you can do is you can apply a foam dressings on that area and connect the suction tubes on that area, so that you can give a continuous pressure in between also. That time that all exudates will come out. So this is how the homemade saline the preparation you can take. Always you can teach the caregivers about how to make homemade saline. Within the hospital, we have a normal saline bottle. When they go back, sometimes they don't have adequate money to buy that normal saline bottle, so that they can use homemade saline for cleaning the wound. They can take 500 ml of water and add 1 teaspoon of salt. Then boil it, cool it, and keep it covered. So that solutions they can use for cleaning the wound. So these kind of wounds are not sterile. This is a clean wound. Clean saline is enough for wound cleaning. Okay. And also you can tell the patient about the homemade dressing supplies also. Usually the palliative care settings will be providing the the dressing materials, but the thing is, if it is finished, sometimes that maybe you can think about the corona time also. We are not able to see the patients. If we don't get that, if we have overcome that kind of situations, they need to manage their own. So we have to educate the caregivers about how to make dressing materials in their home. They can take a cotton sarees or dhotis, and then they can cut into the squares according to the wound size. Then they can steam it. Okay, with the in the idli the cooker. So that if they want to apply Vaseline over it, they can apply before once after dressing, after making cutting the square pieces, they can apply Vaseline or the cotton cloth that pieces, and then put it in the idli cooker and then steam it. So then after that, they can use that dressings for dressing material for wound dressings. So one important thing you have to convey with the caregivers is, before touching the dressing material, they should wash their hands with soap and water clearly. So that is very important.
Sheeba ma'am, we do have a couple of queries about charcoal. Would you like to take that up now or at a later stage?
Maybe later we'll talk. Few more slides is there. So as I mentioned earlier, this is prevention. So prevention is one of the major things here. So we all know that prevention is better than cure. Whenever we have seen a bedbound patients, you have to tell the patients about the prevention of pressure ulcer, the ways to prevent pressure ulcer. This is very important. The first one is position change. So every 2 to 3 hours, they need to change the position. So this is very important. And every 15 to 20 minutes for a wheelchair patients. So wheelchair patients also, they need to relieve their pressure every 15 to 20 minutes. And manage incontinence. So moisture is another cause of pressure ulcer. So incontinence management is also important. If they have a incontinence of urine there, you can advise the patient to put catheter, Foley's catheter. Sometimes the patient is not willing to put a Foley's catheter. That time you can offer maybe they can manage with a diaper. But if it is not affordable, they can use their own clothes. But the thing is, if there is a moisture there, maybe wet they happen, they need to change the sheets as soon as possible. So the next thing is special mattresses. So you can provide some special mattress also, air mattress or water mattress, pillows and air cushions. So there are 2 different types of mattresses are available. One is air mattress and the another one is water mattress. So air mattress is the good one, but the thing is, this need continuous electricity. So there are two chambers. At a time there are alternate rows will be inflating and deflating. So even then the patients can get pressure ulcer, because in between the rows if the continuous pressure is there. Okay, so even if the patient is on air bed or water bed, they need to change the position every 2 to 4 hours, because this will help to prevent pressure ulcers. This is not 100% preventing pressure ulcers. So if you offer this kind of mattress, the caregiver might be thinking this will take care of everything. So after that, they will not turn the patients. So that the patients will get pressure ulcer, even if the patient is the patient is in air mattress also. So this is this important message you have to tell the caregivers. And pillows, you can use additional pillows and cushion for preventing pressure ulcers. So nutrition, hydration, exercise, this is also important. The daily nutritional intake, like a lack of protein intake in the diet can cause pressure ulcer. So nutrition, hydration is also very, very important. And also if they are able to do the exercise, you can encourage the patient to do it alone. So if they are not able to do it, you can train the caregivers to do some passive exercise, so that all the blood circulations will improve, and that way we can able to prevent pressure ulcer formation. The next one is massage. Whenever we turn the patients from one position to another position, like supine position to sideline position, you have to check the pressure points, that pressure, areas, and also you have to massage that area, like back hair. You can take a oil or a liquid paraffin or white petroleum jelly. If there is a white petroleum jelly or Vaseline is not available, you can use coconut oil. Take it, and you can massage on that the area, so that the blood circulations will improve, and that way we can able to prevent pressure ulcer. And also you have to give a wrinkle free bed also. So if there is a wrinkles present on the bed, can cause pressure ulcer. And also give a good nail care also. If there is a nails there is a chance of that the patients will crack, scratch their own skin, and that way the patients can develop pressure ulcer. So these are the prevention, the measures of preventing pressure ulcer. So the next important one thing you have to keep it in mind, double SKIN. So this way we can able to prevent pressure ulcer. Whenever you have seen a bed-bound patients, please keep it in mind, double SKIN. Okay, the first S is supporting surface. Okay, so make sure your patient is getting proper supporting surface. Okay, like air mattress, water mattress, pillows, cushions, or whatever it is, you can you can give these bed-bound patients. You have to think about whether your patient is getting adequate, the patient is on supporting surface or not. The next S is skin inspection. So whenever you have turned the patients from one position to another position, you can give a special attention on that area. And the next, the word is K. K is keep moving. Every 2 to 3 hours, you can change the position. And the next word is I. I is incontinence or moisture control. So bowel and bladder care is very, very important. If possible, you can catheterize the patients. Otherwise, they can use diaper. And the next one is nutrition. Nutrition and hydration is also important. So you have to keep it in mind, double SKIN. Okay. Next. So we all know that within the hospital, our nurses will take care of a bed-bound patients. When they go home, the caregiver will take care of the patients along with the other works. The caregiver will take care of the patient and the other works in the home also. So we need to know how to engage the patients. Without caregiver support, we can't do anything. So we need to educate the patients. We need to know how to engage the patients. So here we how we can engage the patient is patient and that family and the patient care is. So we usually use the word you. You should do like this, you should do like that, you should do like that, you should turn the patient every 2 to 4 hours. You should give a good nutritional food. That kind of things we usually do. But instead of you can use the word we. So if we use the word we, so this is very, very important. They start they will feel like, okay, somebody is behind them to help them, and maybe if they feel more comfort. So you can use start the word we, and also you can give some patient information leaflets also. If possible, you can demonstrate all those things. If that otherwise, you can you can educate the caregivers and give some these kind of leaflets to the patient that can, maybe if they ignore anything, maybe if they forget anything, they can go and see this leaflet, and they will get a good idea about this preventing pressure ulcer. So we have a small video on pressure ulcer prevention. So we'll show it now. Then I'll take your doubts. After that, I'll move on to the cancer wound part.
Bed sores are easier to prevent than to treat. Mr. Sanal Kumar, aged 35 years, is bedbound after a recent accident. Anita is his wife and caregiver. He is being visited by nurse Sumi at his home. Good morning, Anita.
Good morning, sister.
Good morning, Sanal. How are you?
Good morning, sister. I'm doing fine.
Good.
Sister, I want to ask you something. I've heard that people who lie long hours on the bed develop bed sores. I change his position 2 to 3 times a day. Is that enough?
That is not enough, Anita. I shall show you the ways to prevent bed sores.
Okay, sister.
It is very important to change the position every 2 hours to ensure proper blood circulation. If patient has been lying on his back for 2 hours, turn him to one side for 2 hours. Remember to put small pillows between the bony points of the knees, elbows and ankles to prevent pressure on the skin. You can also use folded sheets instead of small pillows. Inspect all the pressure points with a torch. This is very important to detect formation of bed sore early. In a bedbound patient lying more on his back, inspect back of the head, shoulders, elbow, sacrum and heel. If a patient is lying more on one side, inspect ear, shoulder, hip, inner sides of knees and ankle. If there is any color change in the skin, avoid pressure and moisture on those areas. Using oil or lubricant, massage the patient's back with both hands in circular motion, stroke upward from buttocks to shoulders. This will help to improve blood circulation, preventing skin dryness and cracking. Turn him on his back after 2 hours. Then let the patient rest in supine position for another 2 hours. Again, turn the patient in other direction and maintain the position for 2 hours. Repeat this cycle and continue perform massaging and inspection. It is good to use airbed or waterbed as supporting devices to prevent bed sore. Do not make the patient lie directly on the airbed or waterbed. Always use a cotton bedsheet over the airbed or waterbed. If wrinkles are present on bed sheets, the skin rubbing over the wrinkled sheets may cause friction leading to bed sore. So, always provide a wrinkle-free bed. In case bed becomes wet, change the sheet as soon as possible. Keep the bedsheet dry always. If there is urinary incontinence, place a urinary catheter. Nails should be kept short. Otherwise, scratching can cause damage to the skin. Never drag or pull on a bedbound patient. If needed, patient can be lifted with the sheets. Healthy diet is important in preventing skin breakdown. Encourage the patient to take protein-rich foods like egg albumin, pulses, and groundnut. Drinking adequate fluids is important to maintain hydration of the skin. Patients using wheelchair should be made to lift their buttocks every 20 minutes. Use cushions for sitting on wheelchair. Inspect shoulder, buttocks, heel and ball of the foot. Hope you have understood everything.
Yes, sister.
So hope your that video is clear to everyone. Anybody have any doubts on this? Before moving to the next part, I would like to take your doubts and then move on to the next part. So we have received some chat questions. So Placentrex gel we used to use previously, but nowadays we don't use the Placentrex gel, but it is good one. The thing is quite expensive. If there is an affordable person, you can suggest, but that is it's a good one of the good medications for healing pressure ulcers. And management of maggots, I will come to the next part. Any role of spirit sucralfate. So if you apply spirit for back hair, there is a chance of dryness. So nowadays we don't use spirit. We usually we used to apply moisturizing agent. Okay. So the which mattress is supposed to be good? Air mattress is good. But if the patient, that is not a matter. If the patient is on any mattress, they have to change the position. So role of astringent in preventing prevention of ulcers, as I mentioned earlier, there no lotions, no other things we used to use for preventing pressure ulcers. We used to use only the moisturizing agent. If it is not available, you can use coconut oil. So this is that any experience with hyperbaric oxygen? I don't have any experience. Ma'am, any other, do you have any experience about that?
So we generally use HBOT for only ORN cases, but not to increase the, to for any wound.
Sir, your voice is not clear.
So HBOT we generally only use for ORN.
Okay.
But not, theoretically it is given, it helps in wound healing. So that's why I'm asking in any experience in wound healing or dressing part.
Is there any patch available at any of the stages which can prevent
No, ma'am.
further?
No, ma'am. There is no patches are available. You can if there is a pressures are there, if there is a black necrotic issues there, you can remove the slough cutting. You have to debride the slough surgically, and then you can remove maybe fourth stage cancer there. If the patient's health condition is okay, then you can take a surgeon's opinions also, like skin graft. You can try whether the skin grafting procedure. Yeah, ma'am.
No, in stage 2, I mean to say, when the skin is breakdown, then that time, is there any role of any patch you need to, in our place, our dressers, they use that. Actually, I can't say it exactly what is the composition, but they used to try that and they used to keep it for 1 week or 3 days. After that, they used to remove it and they says that it works really
So,
in healing.
Okay,
In healing.
okay. I don't have any experience, ma'am. That
Okay.
so this is the second stage you are telling about.
Yeah.
Yeah,
About the
second stage.
stage.
Second stage is only peeling of the skin. So
Yeah.
that time what we do is we used to clean the area with normal saline and cover the wound.
Yeah.
So that is how we manage here.
Mhm.
and
Okay.
prevent further pressure on that area also.
Yeah, that's it. Okay. Thank you.
Okay. Nano silver is also that McAfee ointment is also good, but the thing is expensive. So if the slough is present, black necrotic tissues present, it may not work well. So after removing the slough, you can apply McAfee, the nano silver cream. That would be nice. That will help help
Actually,
the wound for. Yeah.
that patch I was telling, no, that is Comfil. Comfil. The name is Comfil.
Okay. So we don't use it, ma'am. So I don't know.
That's okay.
Let me check. Let me check. Okay. Thank you. Okay. Next. So sometimes there is only one caregiver and is get difficult for changing the position frequently. What can be done to improve compliance? So what would you say? Any others want to answer this question? Who was asked that question? Please put the chat. So Parul Reina ma'am was asking about if there is a only one caregiver is there. So how will they manage? Is there any answers? No answers? Any idea? No, no idea. So usually what we do is if there is only one we used to train the caregivers, primary caregivers. But if the caregivers, the caregiver also needs some help, no? So in between our community volunteers, we train the community volunteers. In between the community volunteers go there and help the caregivers. Okay, so that the patient's caregiver can get some kind of relief. Okay, so that is how we manage here. Okay. Okay, so next I move on to the fungating wound part, the cancer wound. So I want to ask one question with you all. What are the major difference between pressure ulcer and the cancer wound? You can unmute yourself and talk, or you can put your answers in the chat box. Delayed healing. Okay. Which wound is delayed healing? So, okay, cancer wound. Pressure ulcer is manageable to some extent. Okay. Then. So, I would like to hear from you all. Please put your answers in the chat box. Overlying infection, discharge, okay, poor oxygen supply. If the cancer wound, the cause won't reduce, so pressure. Okay. Okay. Cancer wound is non-healing again. Cancer wounds spread fast. Very good. Cancer wound bleed. Okay. Okay. So thank you for your answers. The major difference between pressure ulcer and the cancer wound is pressure ulcer is preventable and curable. So this is not preventable and not curable. Okay, so this is the major difference between the pressure ulcer and the fungating wound. This is the cancer wound. This is a primary or secondary malignant growth in the skin which was ulcerated and difficult to heal. So this is the definition of cancer wound. So it refers to a malignant process involving both ulceration and proliferative growth. Okay, it looked like a nodular fungus or a cauliflower in shape. So we call it as fungating wound. So not because of fungus, it looked like a nodular fungus shape. That is why we call it as wound is fungating wound. So this is cancer wound. So coming to the pathophysiology of wound, we all know that there is a nodules. Usually there is a development of non-tender skin nodules. Definitely, gradually the skin nodules will enlarge, and if there is a skin nodule, the enlargement of nodules there is a disruption of capillary and lymph vessels will be there. That leads to altered coagulation and tissue hypoxia and necrosis. This is the pathophysiology of that fungating wound. The next one is Marjolin ulcer. Can you hear about Marjolin ulcer? Okay, so this is a type of This is the type of malignancy of the skin. The malignant changes in the chronic wound. So like burn scar, pressure ulcer, venous leg ulcers. So this kind of ulcer can change the Marjolin ulcer, the skin cancers. Okay, so that is the pathophysiology is little bit different. So here appearance of mass in the wound not previously present. So we might be thinking like there is a granulation tissues, but the thing is onset of pain and other problems not previously present. So when we touch that part, the patient complains of pain and also change in character, volume, appearance of drainage. So these kind of changes there, better you can refer the patient to the oncologist and take biopsy and find out whether the patient has have any malignance that developed or not. So if this is a curative possibility cancer, so if these kind of changes there, you can refer to the patient to the oncologist. Okay. So next is problems. So this is non-healing ulcer. From the beginning, the first session itself, you understand that this is palliative care is the total care. It will be improving the main aim of palliative care is to improve the quality of life of the patient and the family. So here is also non-healing ulcer. The patients can have a lot of issues, physical problems there, psychological problems will there, and social problems will be there, and spiritual problems there. So just think about a patient who is having a CA buccal mucosa on their right face. So that maybe CA right buccal mucosa, huge wound developed on their face. So what are the physical problems they can have it, or what are the psychological problems, social problems, and spiritual problems? So there are a lot of physical problems can develop. Okay, let's see one by one. So first one is pain. So one is because of direct exposure of dermis. So that kind the patient can get nociceptive pain. So we learned about the two different types of pain: nociceptive pain and neuropathic pain. And another pain is neuropathic pain. Again, this tumor will be compressing the blood vessels and nerves. That time the patients will experience the neuropathic pain. Okay, and the next thing is while we removing the dressings, old dressings. Okay, so that if the dressings are adherents to the wounds, before soaking the wound, when if we try to remove the old dressings from the wound, so there is a chance of patient getting pain. Okay, and the next thing is malodor. Again, stale exudate dressings have been more than number of days can cause malodor. Again, the thing is Like there are a lot of necrotic tissues. So anaerobic bacterial infections can cause malodor, again bleeding. That improper dressing techniques can cause bleeding. And the another thing is the tumor will protrude the major blood vessels. Okay, bleeding will be there. Exudate. Exudate means there are a lot of the oozing coming out from the wound. So this will be affecting the patient emotionally, psychologically, and spiritually. That there are a lot of issues will develop in the family itself. Okay, there are exudate and malodor. Maybe because of that particular things, that whole family will be affecting. Itching will be there, and infestation with maggots. How does maggots come? Can anyone say how does maggots come? Any idea?
Housefly, due to housefly.
Due to housefly. Any other answers?
Stays uncovered when or a fly or a mosquito, anything, they
So-
can lay.
Thank you. Thank you for your answers. So it comes from house flies. Okay. So usually if the house flies are attracted with the infected wounds. Okay, that time the house flies will touch the wounds. They may lay hundreds of eggs. That time within 8 to 12 hours they come out with egg, the maggots. So this is a very that kind of things. So education of patient, the covering of the wound to the patient is very, very important. So how we have to prevent maggot formation and communication difficulties. So yeah, especially the patient is having head and neck cancers. They are not able to share their problem. They are not able to tell their problems clearly because of their ulcers on the head and neck. So that time what you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems. So that we can able to see their problems and then we can manage it properly. And coming to the psychological part, you just imagine that huge on their face, altered image, body image is also affecting the patient psychologically and socially and spiritually also. Sexuality will be affecting sometimes the patients will deny the growth. Maybe sometimes if even the growths will be that wound size will be increasing. Some the patients will be saying like my wound size is reducing. That kind of things will be answer will be there. Even if they know that the size is increasing, they may tell you like no ma'am, my wound size is decreasing, so the wound is healing well, that kind of thing. But we know the wound is not healing well properly. The wound size is bigger than day by day. So that time what you can do is you not take as a challenge and make them understand, your wound is not healing well, your wound size is increasing. So they will be understanding after after maybe 2 or 3 weeks, they will be understanding gradually. So if they are telling like that, you can listen carefully and leave the patient there. So that you can do whatever you can, and then give a proper dressings and leave the patient there. So after that, they will understand their own. Okay, and fear. That fear will be there, and the patients will be anxious about what happened next, what happened to me next, that kind of thing. If there is any previous experience there, previous family history there, so that maybe inside the mind and keep telling like, oh, what is going to be next, that kind of things will be there. And shame, guilty feelings. So these are the psychological impact of the patient. So what you can do is you have to listen the patients carefully. And social, family isolation. So sometimes the family, one person get these kind of illness, the family members can choose the corner side room and keep the patient there. So they are not allowed the patients to come out of the room. They always keep the patient there. So that will be affect the patients emotionally, and social isolation also. Friends, relatives, neighbors are not willing to see this type of patients because of maybe that stigma, or maybe disease contamination, that kind of things, misconception of this disease, these kind of things will be there. And effects on family, this will be affect the patient's sexual relationship, and marital disharmony also happen. They are not, the people are not willing to marry this kind of family because of maybe misconception of disease, maybe hereditary factors. This will be affecting the patients emotionally. Okay, only because of me, my daughter is not getting married. These kind of things will be there. And spiritual interference with the religious, maybe because of my sin, God punished me like this. These kind of spiritual things will be there. So what you can do is, if possible, you have to do the individual assessment, because in front of the caregiver, they won't tell the truth. They always tell like, okay, she will take care of everything, my son is take care of everything. These kind of things will be there. If you do the individual assessment, they will be telling the truth. So if possible, you can do the individual assessment. So coming to the assessment part, wound locations, mobility, if there is any mobility in body, easily you can able to easily covered with the public view. So this is very, very important, because I have one patient, I remember now also, he used to bring a big towel with him, or with always when he come to the OPD for dressing, so always come with a large towel. So I asked him, why you are bringing the large towel? So he has that buccal mucosa cancer. So then after dressing, so he used to cover the whole the neck, the face. So then I asked, why are you covering like this? Then he said, so if I covered like this, I am that very easy to travel anywhere. So otherwise, people are not willing to sit with me, that kind of things. When I get out of the hospital, people are looking at my face, that kind of things will be there. So if I cover it properly, so I am very comfortable, and I am happy to that walk around, travel anywhere. So that kind of things will be there. And wound appearance, surrounding skin, potential for complications. So this is also important. So if there is any potential head and neck cancer, there is a chance of the major the blood vessels protrude, because the tumor will be protrude the major blood vessels, suddenly bleeding. Okay. So we need to prepare the patient family about how to manage that situations. Then coming to the management part, so this is how we manage palliation of symptoms. So we have to, if there is a pain there, try to control their pain, try to control their order and infection, managing exudate, minimizing bleeding, holistic care. So holistic care is a total care. So we know if there is a, we are able to control their symptoms, definitely we can improve the quality of life of the patient and the family too. So here also you have to think about the total care, empowering the patient and family in own care. So, okay. The next thing is the criteria. So as I mentioned earlier, our aim is to improve the quality of life through symptom control. So here we need an empathetic care, provide a thorough bath before dressings. If possible, you have to ask the patient to take a thorough bath, because all necrotic tissues will fall off, because this kind of wounds are fragile. So without applying your pressure, or if they are able to take a good bath, all necrotic tissues will fall off. And ensure here also you have to make sure that patient is pain-free. So if they have pain, you have to give some analgesics before that, and then you have to do the wound dressing. Here also you can do the normal, you can make a normal homemade saline, and that saline will use for wound cleaning, and select dressings according to the size and the exudate of the wound. So coming to the minimizing pain, Here also, if there is a deep pain there, like aching, stabbing, continuous, this kind of pain there, you can adjust the systemic analgesics. Like, for example, the patient is having morphine 10 milligram 4 hourly. In between, the patients can develop pain. You can give some maybe 1 dose of rescue dose, and then you can do the dressings. Or if they are not if the patient's pain is not controlled with 10 milligram, then you can increase the dose also. So that's how we can manage the deep pain. If there is a superficial pain, like neuropathic pain there, your systemic analgesics may not work well. So that time you can apply local, you can take a local, apply local anesthetic agent like sensocaine or silocaine. So coming to the malodor management, daily cleaning and dressings. So if there is a stale exudate, dressings have been more than number of days can cause malodor. Again, here daily cleaning and dressing is mandatory. Local metronidazole, you can take the same tab metronidazole and make it crush it and make it a powdered form and apply on the wound. And IV metronidazole injection also you can use because there are a lot of pocket formation inside the wound. Your that maybe your metronidazole powder will not go inside. If you are using injection metronidazole, they will go inside and act accordingly. And also you can use systemic antibiotics also, but superficially the blood supply is not good enough, so it will not help much. But you can try a course of antibiotics, and also you have to think about the frequency of change of dressings also. So depends on the size of the wound and the exudate. You can think about the wound that dressings changes time also. Here also no hydrogen peroxide and betadine. So one of the drug of choice of the controlling anaerobic bacterial infection is metronidazole. Okay, if you are not control the malodor with the superficial metronidazole, you can give that systemic. You can give a dose of that orally also, systematically also you can give. So coming to the bleeding part, always try to prevent bleeding. Here, before removing the old dressings, you have to soak well and try to remove the old dressings, because the dressings are adherent to the wound. When we remove it, there is a chance of bleeding. Try to remove before after soak the wound well. And then if there is a small bleeding there, you can apply local pressure. Sometimes that bleeding will stop. If there is that bleeding is not stop, you can apply sucralfate powder. Same we used as for treating for peptic ulcer. That medications you can apply. Crush it and make it a powder form and apply on the wound. And then you can try for tranexamic acid. So if you are not helped those things, you can go for the systemic at arm's length, then palliative radiotherapy. So this will help to strengthen the size of the tumor. That way we can able to prevent bleeding. And also always you have to tell the caregivers about the dark color cloth. If there is a profuse bleeding there, so they can use a dark color clothes for cleaning the wiping out the blood, because that way we can able to prevent the anxiety. So otherwise they will be panic, that others will be panic and the patients will be panic. So that kind of things we can avoid if they can use dark color clothes. So here is the role of cancer therapy, radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. Debulking surgery is also done. So these all the radiotherapy, cytotoxic chemotherapy, hormone therapy, these will help to strengthen the size of the tumor. That way we can able to prevent the bleeding. And coming to the maggots, so as you all mentioned about it can come with the housefly. So you have to educate the patient about covering of wound all the time. So otherwise the houseflies will touch the wound and may lay eggs. So that maybe after that the maggots formation will be there. So if there is a maggots there, you can apply turpentine, not directly pour to the wound. You can soak the turpentine with gauze piece and keep close to the wound. So that time the maggots will come out. So you can take it out with the help of a artifices. Okay, so this is very, very important. When we taking out the maggots. So when we go with your artifices, what happened is they go inside. So if you follow the maggots, your artery forces will damage the blood vessels. Okay, so they go inside and there are a lot of pocket formation inside. They will keep safe there. So if you follow the maggots, your artery forces will touch the blood vessels and maybe damage the blood vessels and start bleeding. So don't follow maggots. Whenever the maggots come out, you can take it out. Okay. So this is how we manage. You always educate the caregivers and patient about how to prevent maggots. Next. So we don't have a case scenario today. This is a patient story. Can anyone please read it out?
Can we have a volunteer to please read out this case scenario for others?
I can do that one.
Thank you, Dr.
Okay.
Shivani.
It's a case of Mr. M, 60-year-old, is a bedridden patient following fall from a height 3 months ago. He has lost sensation and motor power below umbilicus and is having sphincter incontinence. He is unmarried and lives with his older sister. Both of them do not have a fixed income. You are the doctor on home visit and find that Mr. M is having 3 ulcers, one on the sacral area exposing the muscles and other 2 on each heel with loss of skin. So what are the stages of the ulcer mentioned? Mention 3 risk factors and 3 preventive strategies in the care of the ulcers in the patient. How will you manage this patient?
Thank you, Dr. Shivani, for read out the patient story. So I would like to hear from you all. So what are the stages of ulcers mentioned here? So Dr. Narendra said 4. So there are 2 stages are there. One on sacral area exposing the muscles, and the another 2 on each heel with the loss of skin. Sacral area stage 3, heel stage 2. Any
Stage
other
2.
answers? Any other answers?
Stage 2.
So I would like to hear from you all. So we have learned what are the stages. Parul Reina said it's stage 4. Dr. Shivani said stage 2 and 4. Heel stage 2. Dr. Kalji said stage 4 and 2. 4 and 2. Okay, very good. Okay, very good. So here the one on sacral area exposing the muscle, that is stage 4. Okay, exposed muscle, bone and tendon is stage 4. And the other 2 on each heel with the loss of skin. So if there is a loss of skin there, so stage 2. Okay, the first one is stage 4 and the second is stage 2. Okay, thank you for your answers. And mention 3 risk factors. So you can think this. Think this patient. He's having a lot of problems. So what are the risk factors? Okay, immobility, then sensory loss, soiling, then another problem.
Nutrition.
Nutrition. Okay, very good. Age. Any other answers? Bedridden, sensory loss, incontinence, friction, infection due to soiling. Okay. Okay. This is a paraplegic patients having loss of sensation and maybe he may not sense the lower part of the body. Immobility is one of the major risk factor, and the another one is incontinence, friction. So these are then lack of nutrition. It's not fixed income also. So again, malnutrition is also another problem. So these are the risk factors of this patient. Okay, and then 3 preventive strategies. How will we prevent? Regular position change. You can offer mattress. Okay, very good. And you can ask the patient to put Foley's catheterization. Okay, for incontinence of you. Yes, ma'am.
Regular dressing.
Regular dressings. You can. So how will you how will you teach the family? Any idea?
We need to show the dressing, the whole procedure to the family members, and who is the primary caregiver will just ask him to do the same in front of us, so whether he is doing it effectively or not.
Yes.
That.
Thank you, ma'am. So as ma'am said, you have to demonstrate. We can demonstrate the patient, the wound dressing to the primary caregivers. And sometimes what we do here is, sometimes the caregivers are reluctant to do the dressings. So we usually bring the patient and the caregivers here, and we have an inpatient facility also. So we bring them here, and we used to do, our nurses used to train the caregivers. Initially we used to demonstrate the care, demonstrate the dressings, and gradually our nurses try to involve. Can you pour some normal saline on the wound? That kind of involvement. So gradually they'll do it their own. So then we'll give a gloves and put the gloves, and then our nurses involving the patient, the caregivers in patient care. So once they get trained, we will send back to their home, and our home care and the team will do in the follow. So that way we manage this kind of patients here. So you do one thing, you can as much as possible, you have to train the caregivers, and you can try to demonstrate the caregivers for home care. So then only they will know how to care, how to do the dressings. Okay. So here we can offer that you can train the caregivers about the changing positions, offer air mattress. Then for incontinence, you can put Foley's catheter. Then saline wash. Okay. So for stage 4 pressure ulcer, you can do one thing. You can, if the patient's health condition is okay, you can take a surgical opinion. So if the health condition is not good, you can clean the wound. You can do the symptom management. Like if they have pain there, you can do the pain management, and cleaning and dressing is also you can do. That kind of things you can do. So this way we can able to manage. Even if the patient is in home also, you can, for nutrition. So that is also important. So if they are not having enough money, how will they bring things. So they don't have money, no. So what you can do is you can think about the food kits also. You can engage the company. You have to inform the panchayat member or local councillor, and that maybe try to involve the community in that patient's care, or the NGOs will give some food kits. So we are providing a lot of food kits to the patients. So here, if their health condition is not good, if there is no earning member in that family, you can think about the food kit also. And also you can think about the financial thing also. If the caregiver is able to do the occasional rehabilitation, you can think about the occasional rehabilitation also. So any other things you want to discuss?
I just wanted to know why betadine lotion is not being used and hydrogen peroxide. Is there any role?
Yes,
Because at
ma'am.
times
Both are the hypochlorite solutions. It will destroy the granulation tissues.
So, but at times, can we use that hydrogen peroxide? Actually, in fact, we are been using it occasionally to remove all those slabs and. So, is it advisable or not? Not at all.
In here, our that surgeons also not advisable right now. Here, they are requested if there is a stage 4 pressure ulcer there, they used to tell us to use betadine. If you use betadine, you can dilute the betadine. So
Okay.
after dilute the betadine with normal saline, after if dilution also they used to tell us, after washing with that diluted betadine, then you can wash out with normal saline. That is mandatory.
Okay. Yeah.
The
After
normal
using
saline,
it.
yes, the normal saline is enough, ma'am. So I think that normal saline is enough. But if you can use betadine, you have to use it as a diluted thing. So otherwise,
Actually,
that
when there is much of slough, no, it's too much of slough. That time only we used to use that hydrogen peroxide also along
no,
with.
ma'am. There is no role. If
No
there is a
need.
slump, no need and no
role.
role. If there is any slump there, you just remove the slump.
Okay. Okay. Thank you.
Okay. Any other doubts? So how do you use ether? So here here we are using that turpentine oil for removing maggots, but other places some other that members told me that they are using ether also. Maybe either also you can use, but I don't have any experience. We usually use turpentine. Any other do you have any other persons who have any experience on that? Ether?
No.
Okay. Better you can use the turpentine oil. So not directly pour to the wound. You can soak it with the gauze piece and keep close to the wound. That time that maggots will fumigate it, and they will not tolerate inside the wound. They will come out the wound. That time you can take it out. Okay. So we can wind up the session. Thank you all for the interactive session. So this is very nice. So I'm enjoying a lot. Thank you for your contributions. Thank you.
Thank you, Sheeba ma'am. I believe that as I promised, this also turned out to be an interactive and interesting session for every one of you, because I am seeing a flow of thank you messages out there in the chat box, which really makes us happy that we could at least provide at least one new information to everyone out there. We would be thankful for that. So with that note, this is Sri Priya along with Sister Sheeba signing off from the Tips Echo Hub. See you on Monday with another interesting topic and yet another eminent faculty. Till then, everyone, take care, be happy, have a nice weekend. Bye-bye.
Thank you.